Hey guys, it's Diogo Trevisan. Making this video to clarify some stuff about the shoulder joint. So first, let's understand the shoulder joint as a complex. So the shoulder has not only one joint but four. We're talking about the sternoclavicular joint right here, the AC joint, the acromioclavicular joint, the glenohumeral joint, and the scapula-thoracic joint back here, the scapula articulating with the ribs. All this complex has to move together, work together, and be in harmony as far as flexibility, strength, and neuromuscular control. So the shoulder has static and dynamic stabilizers. What are static stabilizers? Static stabilizers are the soft tissue that help to stabilize the shoulder joint. So we're talking about the ligaments. They are reinforcement of the capsule. You can see the capsule joint here, and these thicker bands are the ligaments reinforcing the capsule. The capsule itself, synovial membrane, the labrum, you can see here, they don't contract. We don't have any control over it. So you were born with a type of soft tissue. Some people are tighter naturally, they're more rich in collagen type 1, and some people are more flexible because they have more elastin instead of the collagen type 1. Okay, so if you are a hyperflexible type, you're looking at strengthening when fixing a shoulder problem. Regardless of what it is, you have to look into some strengthening. Now you may be too tight and you may be looking at a lot of joint mobilization, stretching, and everything. So the one thing that I'll be talking about today, and the main thing that I want to stress, is there is a myth in this sports field, weightlifters, athletes, that they believe that just by strengthening your rotator cuff muscles you can fix any shoulder problem. Okay, and you see people talking and someone will say, oh, my shoulder is hurting, and they say it's probably your rotator cuff. It's the first thing that comes to mind. This is very incorrect. The shoulder is very complex, and there are a lot of structures that can be damaged. Like we just said, sternoclavicular joint pain, AC joint pain, labrum tear, synovitis, capsulitis, long head of the biceps tendonitis, short head of the biceps tendonitis. There are several conditions that can affect the shoulder and is not directly related to a rotator cuff problem. So there is this myth that strengthening the rotator cuff will fix the shoulder, and it does work sometimes. Let's get into it. Why does strengthening the rotator cuff actually help with your shoulder pain? So if you look at the position of the rotator cuff, they are in close relationship with the scapula. So you can see right here will be the supraspinatus, the infraspinatus is down here, the teres minor is right here, and the subscapularis is if it were from underneath the scapula going to the other side, the subscapularis. So if you look at these muscles from a biomechanics perspective, the force that they are creating, they are holding the head of the humerus to the scapula. Okay, can you see that? When they contract, there's a shortening. They are holding the head of the humerus against the scapula, against the glenoid. So they are biomechanically important, in the abduction, the supraspinatus, after 60 degrees of abduction, it becomes a stabilizer because it's way shorter here, and the humerus will be, you know, a little higher. So the humerus will be higher up here, and the supraspinatus will be a direct stabilizer in this position. So biomechanically and anatomically. So it is true that strengthening the rotator cuff is a major step in shoulder rehabilitation. However, what is shoulder pain? What is going on when there is shoulder pain? Inevitably, there is no way around it. Every time you have shoulder pain, you have inflammation. Okay, inflammation is a response to aggression. When there is aggression in the body, their cells, healthy cells, die and release chemokines that start an inflammatory process. So that injury can be sudden, like someone is bench pressing and drop the weight on the shoulder, or have a partial tear, a full thickness tear, or it can be over time, like overuse type of injury, that the tendon start micro tearing, those cells are dying, starting an inflammatory process, and that inflammation chronifies. Chronic inflammation start impairing the microcirculation, the microlymphatic system in the area, and it may never go away. So people take anti-inflammatories, doesn't go away. They try injections, dose pack, and nothing really gets rid of the inflammation. That's how joint mobilization, deep tissue release, and manual therapy plays an important role, because they increase the circulation in the area, in the tendon. They activate the microcirculation that is impaired because of the inflammation, and help with the healing. Okay, so if you have inflammation, and let's name just a few anatomical landmarks: the synovial membrane, you know, it's very common in the shoulder, synovitis, in the capsule, typical capsulitis, tendonitis, you know, let's say the long head of the biceps, which strengthening the rotator cuff may not do much directly to it. Okay, it will, and we'll get into it, but not directly, you know, in the first place. Then strengthening the rotator cuff is not going to do much. Okay, the long head of the biceps is prone to impingement against the coracoacromial ligament. So the long head of the biceps is prone to impact right here against the coracoacromial ligament. So look, this is the long head of the biceps. This is the coracoacromial ligament. When you're doing overhead activities, the long head of the biceps can be impacted against the coracoacromial ligament. Typically, weakness on the rotator cuff may cause the head of the humerus to glide up instead of rotating on its own axis, and that makes the long head of the biceps impinge against the coracoacromial ligament. Now, if you're too tight and your problem is not really instability, then stretching and joint mobilization is really what's going to fix the problem. So here's the rotator cuff in a more realistic image. In this one, you can see the subscapularies, like you're seeing an anterior view. The ribs should be in front of it right now, but it's not. So you can see right here. See, the ribs are right in front of the scapula. The subscapularis is right here. It's a very important muscle, very important stabilizer. So like I was saying, there is this myth that strengthening the rotator cuff just fixes a shoulder problem. It is a combination of stretching when the patient is tight. You have to know how to test, do manual muscle test, get an end feel to see if it's what kind of vent feel the patient has when you're stretching. You have to check the range of motion. You have to check overall strength. You have to check the neuromuscular control. And you have to check how the scapula is winging, okay? So the scapula, let's assume this very scapula you're looking at starts in this position. And this is the head of the humerus. So this is the spine. So when it goes in abduction, it should wing that way in abduction. If it doesn't wing, it was supposed to go all the way up here, open up the glenoid, open up the space for the head of the humerus and wing. See how it wings like this to the side. And then now the glenoid is pointing up. So the glenoid right here is pointing a little more medially, more laterally, and anteriorly. In this position is pointing more superiorly, so it opens space for the head of the humerus to go all the way up and overhead. Okay, so if, for example, your rhomboids muscle are too tight and the mid and lower trapezius, they're too tight right here, the scapula is not winging like you're seeing this image. Okay, and then what happens is when the head of the humerus is trying to rotate up, like in this position, instead it'll be impinging here against the acromion and, like I said in the other image, the coracoacromial ligament. Okay, so let's make an assessment. The hand behind the back should touch the opposite scapula. Overhead, it should be able to touch the opposite shoulder. That's how you check, more or less the range of motion. We all know how far the flexion goes, 180 degrees. External rotation, about 85 to 90. 80 is still considered normal. Check the range of motion. If the patient is too tight, check for strength. Some athletes are extremely strong in their rotator cuff, but they are just really tight and you have to work on mobility. Watch both scapulas winging, see if they have a good winging motion. Weakness of the serratus anterior muscle can also cause this type of problems with winging the scapula. The serratus anterior muscle is right here, if you guys can see. It's right here in front of the scapula, attaching to the ribs, and he pulls the scapula forward. Okay. Include that in the assessment. Yes, rotator cuff exercises are very important for shoulder rehab, but don't forget tightness, instability, really identifying the cause of the problem. My next video, I'll be using an actual model. I'll be working on him, showing the landmarks for palpation, discussing some special tests, diagnosing, and treatment. Thank you so much, guys. Stay tuned. This is Diogo Trevisan.